Welcome, my name is Thomas Zeller from the University Heart Center Bad Krozingen in Germany. I'm here together with Marianne Brodmann and with Michael Lichtenberg from Arnsberg in Germany. We are convening here today to discuss the latest data release of intact vascular TAC endovascular system, which was presented during a TCT 2019 late-breaking trial session by Marianne. So Marianne, could you briefly summarize these really outstanding outcomes after 1 year of the TAC system, which was implanted after vessel preparation with a drug-coated balloon in femoral popliteal lesions?
Yes, thank you, Thomas. I think this is really an outstanding study. It was a single-arm post-market study where we used the DAC in addition to a TCP, the Impact Admiral, in Europe to treat dissections. So we only treated patients with dissections in the fem-pop artery. Yeah. There were two groups. The lesion length in the standard group was up to 15 centimeter, and there was also a longer lesion cohort with lesions up to 25 centimeter. We had a fair amount of total occlusions in both groups, and a DAC was used after each TCP if there was a dissection. With regard to the primary patency, this was outstanding. 12-month primary patency was in the standard lesion group up to 15 centimeter, 95%, and in the long lesion cohort up to 89.3%. And this was also in accordance with a good clinical benefit. Clinically driven TLR was low in both groups, a little bit higher in the long lesion cohort, but still very good. And this was also in accordance with a good clinical improvement. So patients changed with regard to Rutherford category more than 3 classes in the main patient population.
To clarify, in the entire patient population, which was 201 patients in total, every lesion presented after drug-coated balloon angioplasty with a dissection. What about the number of regular stents that had been implanted?
Only one. So there was only one bailout stenting. So 201 patients, only one bailout stent. Very low, and this was not in the long lesion cohort. This was in the standard lesion cohort. So in the shorter lesion cohort.
So Michael, if we look into the recent data of TOBA II that had been released during VIVA 2018, this cohort included patients treated with plain balloon, patients with the Lutonix drug-coated balloon. How do the data we have now been presented within the TOBA III study, how do these outcomes relate with TOBA II, and what's your major learning from looking into those two study outcomes?
So the TOBA III data, which you just mentioned, I think are perfectly in line with the TOBA II data. We saw that in the TOBA II data, regardless if it's POBAR or the DCB, the efficacy data were significantly better, either using POBAR or DCB in comparison to other studies. And that means that we need to discuss about the importance of dissections. And this is something I definitely learned from these studies, to take more care about dissections. And I think this is something we definitely need to discuss.
You mean even if they are not flow limiting?
Yeah, this is a very important question. In the former times, we only said, if it's a flow limiting dissection, then we have to care about it. We have to post-balloon it, or we have to implant a stent. So these data are probably giving us a hint that even if dissections are not flow limiting, we have to take care about that.
Yeah, well, that's a very important viewpoint and consequence of both TOBA studies. When we performed the first DCB trials, we learned that dissections are nothing bad in terms of the outcome following drug-coated balloon angioplasty. This was our finding of a retrospective analysis of the Sander data. Now the key question is, looking on TOBA III in particular and comparing those data with the IMPACT SFA trial, 1 year outcome, there is an incremental benefit, obviously, of using tags in every kind of dissection as compared to leaving simple dissections like type A to C dissections untreated. Relevant dissections had been treated with regular nitinol stents within the IMPACT SFA trial. Now, in the TOBA III study, in a patient or lesion population which was very similar to IMPACT SFA, we have seen this incremental patency and with this also freedom from TLR benefit. So this may change, at least my view, in considering treatment of simple, not flow-limiting dissections in the near future. Well, Michael, you are one of the most frequent users since the tag system became commercial in Europe, and in particular in Germany. What's your experience with regard to visualization of dissections? What is of importance, and is there a learning curve implanting tags as compared to regular nitinol stents?
So I believe the most important thing is that you have to identify a dissection. So you have to perform different angulations during angiography to identify dissection. As we just highlighted, that these dissection treatment are improving patency rate. So therefore, we change a little bit our protocols and perform different angulation after POBA and DCB or whatever to identify dissections. And this is the learning curve we went through. Yeah.
Let's come back to this. In your opinion, is it sufficient to do two different views in your final angiogram in order to identify dissections after any kind of balloon angioplasty, or do you see a value of additional image-giving technologies like IVUS? Is it really necessary? I know in the US it's very popular to do it. In Europe, in particular Germany, it's not reimbursed. What's your impression?
So at the moment, we do not have enough data to really say we need to do IVUS to really judge this is a dissection which needs to be treated. We have a lot of knowledge about angiography diagnostics for identifying dissections. So at the moment, I think doing at least two different angulations is the way to go if you don't have IVUS, and I can only encourage that we should do IVUS studies, performing scaffolding after IVUS diagnostic to learn more if IVUS can have an additional benefit.
Yeah. But in this context, it's, I believe, of importance to note that the outcome of TOBA III is simply based on looking angiographically on the presence of dissections. So if we would really increase efficacy by performing IVUS, identifying additional dissections by IVUS, there's a very high bar of further improvement of the outcome. Well, we are close to 100% now with patency, and it will remain a question whether additional costs will really be justified in order to further improve outcomes. My last question to you with regard to the learning curve, is there something specific which is different between a tag release and a stent release, a nitinol stent release?
So the learning curve is not difficult, it's not very complex, and after a few cases, you get very soon familiar with the system.
Same impression?
My expression is the same. We all used a lot of tags during the studies, and the placement of tags is very easy.
So it seems there is a high accuracy of placing tags into dissected vessel segments. So I thank you for your attention, and I am looking forward to get the release of the TOBA II BTK study data soon during the VIVA meeting. Thank you very much.